this portion of the meeting.
Okay. I'd like to call to order this meeting of the Knoxville-Knox County Council on Aging. Welcome to everyone. First off, the executive committee met.
I can't.
Okay, for those of you who are online, please make sure you're muted. Sometimes we can get an echo if you're not. So before this meeting, the executive committee met and we voted on allocation funding of the Older Americans Act. We typically get that money on about July or August, although it can vary. And we made virtual site visits this year to each place that's requesting funds and determined that we were in agreement with these groups having the distributions. Aside from that, we went over some old and new business, and I think that wraps it up for me. So Dottie, are you here?
Yes, I am.
Okay. There she is.
Good afternoon. I'm Dottie Livers with the Office on Aging. And I just want to share one thing with you. First of all, many of you last year knew that or attended our O'Connor Center Pancake Fest, which was early March. This year we are doing that a little bit differently. It'll be a drive-through event and senior expo. So you can come and get a box of like a bunch of pancakes and goodies, and then participate in our senior expo with local vendors and informational tables. That will be on April 16th from 8 a.m. to 12 p.m. at the O'Connor Center parking lot. There is more information that we can share, or you can visit our website at knoxseniors.org for more information. Tickets are available if you're interested in going ahead and prepaying for some boxes of pancakes, but we'd love for you all to attend and enjoy a nice breakfast with us. Other than that, we are always here for you at the Office on Aging, and our number is 524-2786 if you need anything from us. And I'll turn it back to Angela.
Hi, everyone. I'd like to introduce our speaker, Carole Myers, PhD, RN, FAAN. You'll have to tell us what that one is. But Dr. Myers is a professor at the University of Tennessee College of Nursing. She is the creator and co-host of Health Connections, a biweekly radio show featured on WUOT-FM, the Knoxville NPR affiliate. If you haven't listened to it, it is a great segment. Health Connections focuses on issues related to people, health, and policy. And we have her here today. Welcome, Dr. Myers.
My pleasure to be here. Thanks to you, Angela, and the board of directors. But most importantly, thanks for those of you that have dialed in or connected to today's presentation. Please save your questions. I look forward. The best part is at the end is hearing your questions and comments. So don't disappoint. Write some things down that you want to talk about. I've been asked today to talk about mental health matters, specifically depression and anxiety in older adults. Let's see. So I want to start pre-pandemic. That's my baseline. Remember what things were like before a year ago. At that time, our baseline was about 20% of people ages 55 or older experienced some type of mental health concern. These can range from anxiety, cognitive impairment, mood disorders, and the main one being depression. We also know that mental health issues are implicated in cases of suicide. And the reason I mention this is because older men have the highest suicide rate. So when we look at their rate, it's 45.23 per 100,000 people, just the way we look at things. And in the general population, that number is 11. So 11 for the general population and 45.23 for older men. So for that segment of the population, suicide is something that we focus on. I want to make a strong point, and I'll make this point other times during the presentation. Depression is not a normal part of aging. Some people want to dismiss it as if it's inevitable. It's not inevitable. And if you have depression, it's highly treatable. So those are important things to remember. So what is depression? When we talk about depression, we talk about something that affects the way you feel, the way you think, and how you handle your daily activities, such as sleeping, eating, working, volunteering, spending time with your family and other loved ones. Depression is more than feeling sad or blue. Circumstances will make us sad or blue from time to time. Depression is much more than that. It's common, but it's a serious mood disorder. And in one study, and you'll see sometimes the numbers that I'm going to present to you don't all entirely line up. They come from different studies, or they're talking about different age groups. But in one study, 27% of older adults that were assessed met the diagnostic criteria for depression. And an additional 31% had symptoms that were bothersome, but together did not meet the diagnostic criteria. And we know that the symptoms are severe. The people suffering from depression truly are suffering. The next condition that I was asked to look at, and I always think it's good to start with a definition, is anxiety. So when we think about anxiety, we think about symptoms such as excessive nervousness, fear, and worrying. You may also see physical feelings such as chest pains, headaches, sweating, GI problems. And just like depression, one of the hallmarks of anxiety and what makes it be that serious condition versus just a situational condition is that it interferes with your daily activities, sleeping, working, eating, being with your loved ones, etc. Anxiety is not quite as common baseline pre-pandemic, affecting about 3 to 14% of older adults. And just like the statement I made about depression, anxiety is not a normal part of aging. So when you hear that, I hope that you will challenge it. And if someone is expressing these sort of feelings, is suggesting that maybe they should get those checked out because there is help. Now, when we talk about anxiety, what we call general anxiety disorder, GAD or GAD, is the most common. And what we see with that is chronic, exaggerated. Chronic means it goes on for a long time. Exaggerated worry. It's beyond the normal, what time will the kids get home? I hope they're got their seatbelts on. I hope no one's taken in any alcohol and driving. It's beyond that. So it's exaggerated worry about everyday routine life events and activities. It lasts at least 6 months. And it's a feeling of almost always anticipating the worst, even though there's little reason to expect it. So, and as we've already said, there's very pronounced physical symptoms that go along with generalized anxiety disorder. One of the things that is particularly concerning about mental health problems such as depression and anxiety is too often they're not treated. But as I said earlier, they're highly treatable. About 80% of disorders can be treated, but only if they are recognized, diagnosed, and treatment is prescribed. So those are important things. And again, if I had a magic wand, assessment of people's mental health would be as important as their physical health. We would have the same intentions around looking at what's going on with our feelings as we do our blood pressure, our blood chemistries, etc. Another thing that we suffer from in this country is there are a lot of barriers to care for mental health. And the two major reasons there are availability and affordability. And when I say availability, that means that there are mental health providers. Nationwide, we have a major shortage. And here in East Tennessee, we have a pretty major shortage. And when you move out to the rural areas, it's much worse. And then affordability. There is supposed to be parity in Medicare and other programs between how we treat physical disorders and mental disorders, but this doesn't always play out the way it should. And if you are someone who is on Medicare, I would take a close look at the mental health benefits if I was looking at an Advantage plan. Medicare Advantage plans are often very attractive because of the additional benefits, but you need to make sure that it's not at the expense of mental health benefits. When we talk about the barriers to mental health care, I do want to note that the barriers are greater among people of color and those of lower socioeconomic status. Then you might ask, well, why don't people ask for help? If they're suffering, chronic sadness, chronic anxiety, interfering with daily life, why don't they ask for help? Well, there's a nuance about mental health problems that is so important. It's stigma. There's stigma associated with the admission of having mental health problems, feeling depressed, being lonely, feeling hopeless, having thoughts of suicide, and this is a significant barrier to care. So stigma is one of the things in all populations relative to mental health that we have to be worried about. But again, certain populations, stigma is an even heavier burden, and that tends to be among populations of color. What I'd like to do now is, so how are things here in Tennessee? I went to two reports that I use because they're kind of enduring reports with very good methodology, and we can look at data over a long period of years. The first is America's Health Rankings, and I'm encouraged that in recent years they've started doing a senior-specific report. And what they do is they rank all the states on certain measures from top to bottom. If you are the best state, you're number 1, and if you're the worst state, you're number 50. In two of the things that I pulled out relative to mental health, Tennessee is in the ranking between 41 and 50. So the bottom, the dregs. And that's in community support, which is so important, as we'll talk about, in giving people support and the social connection that they need, the resources they need. And then Tennesseans, not only seniors, but also other adults, have a very high frequency of reported mental and physical distress. Basically, on the survey, they ask you how many days in the last month did you suffer from physical or mental distress? And Tennessee is among the worst states on those two measures. Now, in the measures where we are moving up ever so slowly towards the middle, so rankings would be 31 to 40, is the risk of social isolation. I'm going to talk specifically about social isolation in a moment. Volunteerism. You might think, well, that's an odd thing to be on that list, but we know that volunteerism is a way to connect with your community and other people, and it actually helps to lower your risk of certain mental health disorders and social isolation. And then even stranger, you might say, is voter turnout. We are not where we need to be in Tennessee on voter turnout, but the reason, besides it's our civic duty and it's part of a vibrant democracy that voter turnout is so important, is because it involves civic engagement. And just like volunteerism, it offers us some risk reduction properties. The more engaged I am with other people and with the activities of my community, the more protection I have or lower risk for depression, anxiety, social isolation, and other issues of similar description. I want to look next at the second report. Some of us call it the BRFIS. It's the Behavioral Risk Factors Surveillance System and Indicators Report. It's done by the CDC, the Centers for Disease Control. And Tennessee got not such a good grade card on these things. Low social support, that tracks with the America's Health Rankings report. High life dissatisfaction, very high. That was disturbing when I looked at that map. High frequent mental distress, just like the America's Health Rankings. High current depression, and high lifetime diagnosis of anxiety. So sometimes when we step back and we say, well, how is it really in Tennessee? And we look to see how disparate in the wrong direction, the bad direction, we are from other states. That is a concern. But I don't want to be all gloom and doom. It's not my style. There is good news. And we do know about older adults that as you get older, thank goodness, lower stress reactivity. Things just don't bother us as much as we age, and better emotional regulation, less emotional outbursts, less just crashing and having the worst day because of something that really maybe wasn't that big of a deal. So most older adults have this sort of protective shield around them. I see it as a benefit of living long is lower stress reactivity and better emotional regulation. But this isn't true for everyone. There is a mental health crisis among older adults who have limited interactions with friends, families, and caregivers. And this is my segue to talk about social isolation. I talked about social isolation to this group 2 or 3 years ago. I meant to look it up. It was just when the AARP study came out that really started to shine the light on social isolation and its devastating effects. What we've seen is a very sharp decline in social connectedness in the past 20 years in our country, and actually it's being shown in other advanced countries. 25% of Americans, according to the AARP study, no meaningful social support. 25% no meaningful social support. 50% of Americans reported no close confidant or friends outside of the immediate family. Now, I do want to couch this as this is adults, not just older adults. Then they looked at Medicare eligible individuals. 14% were found to be socially isolated. And this to me is really sad. They interviewed folks as part of the AARP study. Many older adults go up to 1 week without even seeing one person. And this is described as devastating. It's really hard for me to imagine not seeing someone else for a week, unless it was by choice. And some days that sounds good, but not today. Okay, so what is social isolation and why are we talking about it so much? The most simple definition that was put forth by AARP was the lack of meaningful contact with others. And why it is so important is it imposes significant risk for poor health and increased risk of death. And in some ways, initially, social isolation was described as harmful and similar in some ways to hypertension, because before diagnosis, the harm has already been done to the body, and many people are not aware that they have hypertension, just like they're not aware that they're socially isolated until it's too late and damage has been done. So social isolation is a very real health problem. But let's talk about it, because there's a lot of terms that get thrown around that aren't the same, and yet they're used interchangeably. So I've divided the terms I'm going to talk about to those that are objectively, they can be measured, or those that are an experience that an individual has, they're subjective. When we look, some people consider a person socially isolated just if they live alone, they have less than monthly contact with families and friends, they do not belong to any groups, they lack a sense of belonging, lack of social engagement, they have a minimal number of social contacts, and what's very important is a deficiency of fulfilling and quality relationships. So that's the actual thing we can look at. We can ask people, how much contact did you have? Who do you live with? What are your feelings? But then there's these more subjective terms. Perceived isolation is a subjective experience of the lack of companionship and support. So we can know that someone lives alone, but that feeling of isolation is what the person feels as a result of living alone, and not everyone feels that. When we talk about loneliness, this is a very difficult concept at times, but it really includes the lack of social intimacy and/or deficiency in social relationships. You still have people that you interact with, but those interactions are very unsatisfying. Part of perceived isolation is, well, you can perceive that you're lonely. Let me try to say this a different way that's easier to understand. You can perceive being lonely even amongst people, is what I was trying to say. You can have social disconnectedness without perceived isolation. So it's two sides of the coin. Where do we see loneliness most commonly in America today? We see it with folks who live in rural areas, folks who are older, living alone or in residential care, widows. Low level of education puts you at higher risk, low income. And really what loneliness is there's a deficit or a discrepancy between the desired and actual social relationships. So it takes into account that each of us is different and have different needs as far as social connectedness. So some people may be physically able to go out and meet people, but are inhibited because of depression, being a caregiver because they're grieving, and even though they're out and about, they're not connecting. Caregivers consistently describe isolation, but it's different. We know that many caregivers are not stressed because of isolation. They generally describe positive feelings such as reward associated with caring for someone, but they're not having those other relationships. And we know something else about loneliness. Lonely people may suffer from depression. So we'll see things like disrupted sleep, daytime dysfunction, impaired mental and cognitive function, and then other stress responses such as getting sick easier is part of the loneliness cluster of symptoms. So let's look at, and a profile is only as good as the generalities. It doesn't apply to anyone, but social isolation is across all age groups. However, older adults are at higher risk. When you have chronic disease and disability, it puts you at higher risk for social isolation. Men, more so than women, are socially isolated. Depressed people, we've already talked about that. People who, for whatever reason, are having difficulties with activity of daily living. That's where disability comes into play. And then again, we've said this several times, lower education and economic status confers greater risk. So folks are lacking a sense of belonging or engagement, lacking social contacts, and fulfilling and quality relationships. So the deficiencies can be at multiple levels within the family unit, within the social structures with friends, and then at a societal level, that people aren't engaged either through church activities, civic activities, volunteer activities, etc. So what's the big deal? What are the consequences of social isolation? Well, the big one is much higher risk for poor health and death. As a matter of fact, the health risks associated with social isolation have been compared to smoking 15 cigarettes per day. Now, we all have a pretty good conception of the ill effects of smoking. For some folks, it's a leap to think those same ill effects are conferred upon people who are socially isolated, but that was the result of the AARP study. Insomnia and feeling disconnected. People who are suffering from social isolation have a 30% increased risk of dying in the next 7 years, and twice as likely to die prematurely. So there's also connections between loneliness and social isolation and dementia, stroke, anxiety, and suicide. Moving on, I've got a few more. Children have significantly worse health 20 years later. So what happened in their childhood is carried forward. Cardiovascular disease, hypertension, premature cognitive decline, and may increase your vulnerability to various forms of addiction. So we do not definitely know whether efforts to decrease isolation and loneliness result in improved health. That has not been shown definitively by studies. But we do know that evidence linking social isolation in old age with poor health is strong enough to act on social isolation to reduce at least cardiovascular disease. The connection there between social isolation and cardiovascular disease is the strongest. So what can we do about it? Well, increased screening. It's the same thing I said about mental disorders, is we need to know that those disorders are there so we can act on them. Many people are advocating for initial screening when people have their welcome to Medicare visit. Home-based care rather than institutional care decreases depression, increases quality of life and functional status. So a lot of move to keep people in the home environment or home-like environments as much as possible. If you are separated from your family members by great distance, we need proxies. We need neighbors that will check in on our parents or our friends who are older. We need to be assured that the social contact that perhaps we can't provide in person or otherwise, that other people perhaps are doing that. There's a physician in California who started what's called a cross-generational service exchange. I love this idea. This service allows one person to post a need, such as, I want to play backgammon with someone tonight. The volunteer that answers the bank hours so that when there's a need, another volunteer can meet their need. So basically, we have people signing up to help other people meet their needs. And I see this as mutually beneficial. I think the person asking for help and the person giving help are both going to benefit from the relationship. And then we know that technology, as incongruent as it seems, can actually help to decrease social isolation. And we've certainly seen this during the pandemic. So we have hands-free, voice-activated devices that perhaps, Alexa could say, hey, when's the last time you went outside for a walk? Or guess what? They're having a meeting at the Office of Aging and there's a speaker. You need to go there. You'll get to see some good people when we're all back together in the building. To remind you to exercise and even perhaps have conversations with people you don't know that equally are looking for conversations. But there is a caveat. Interventions that rely on technology, while they're better than no intervention, they're still not the same as in-person interventions. We've learned that during the pandemic, and not all people have the same access to technology. A lot of disparities, which again have been revealed very markedly during the pandemic. So why don't we talk now about the pandemic and what its impact is on our topic of the day. We know that the rates of depression and anxiety have been higher. They're now 1 in 4, that's 24%, ages 65 or older, reported anxiety or depression during most weeks of the pandemic. So that's an uptick in these numbers. And according to their comparison point, that's an uptick from 10% to 24%. And then between May and July 2020, and remember, this was long before the worst part of the pandemic, the percentage of older adults reporting anxiety or depression increased from 39 to 46%. I could not find studies that followed this same track, but my estimate would be it would continue to go up, particularly in those very dark months of November, December, January, and spilling over even into February. So again, we're now making a very intentional shift to look at our current times and circumstances and be pandemic focused. So what are the pandemic stressors that have been experienced by older adults? Well, very real. Higher risk of serious illness complications. Many common conditions that are seen particularly in older adults increase your COVID risk. And 86% of older adults have at least one chronic disease and 56% have two. So things like hypertension, high cholesterol, arthritis, heart disease, diabetes, kidney disease make you particularly vulnerable to the COVID virus. And this is evidenced in the fact that 80% of the COVID-19 related deaths have been among older adults. So that is a major stressor. Limited in-person social interactions have particularly hit hard with older adults. Disruptions of daily life and access to care. So habits seem to matter as we age, maybe more than when we're younger. And I haven't experienced this yet, but I know with caring for my mother-in-law and my parents that part of the daily routines has to do with healthcare visits, and those were markedly disrupted. And then older adults during the pandemic have been subjected to new burdens. I have felt some of these, being a grandmother of 3 boys, is increased childcare responsibilities, and some grandparents are the ones supervising the remote learning of our children. So it has been a big deal. Now, I want to go to this third bullet, and if you're on the phone, you don't know what I'm talking about, so I'll read it. Limited in-person social interactions. I've lamented throughout the pandemic that the terminology is causing us a lot of problems. We definitely need and we still need to be physically distanced as a way to manage the pandemic. But it's been erroneously referred to. I hear it every day on the news, commonly in conversation, that we talk about social distance. Social distance is not necessary during the pandemic. What's necessary is physical distance, and we have to look at how to reconceptualize how we maintain social closeness. So if maybe one thing you might want to do is try to change your words. I had to do that early in the pandemic and throw out the idea of social isolation or social distancing and separate and name it physical distancing, which is what it is. Okay, so let's look a little bit. This is grim. This is not a feel-good chart. I want to look at pandemic morbidity and mortality among older Americans. The risk for people for illness and complications related to COVID, ages 65 to 74, is 5 times greater than the general population. If you're over age 75, it's 8 times greater. So there is reason for concern there. And then when we look at deaths, if your age is 65 to 74, the risk of death is 90% greater than the general population. And when you move over age 75, in that range from 75 to 84, it's 220 times greater. Now, this is one of the things where we have seen improvements since the beginning of the pandemic to later with understanding of treatments needed, etc. But it's still a concern for older adults. But there are some bright spots too. The rates of anxiety and depression in older adults during the pandemic, even though they've gone up, are lower than seen in younger adults. So now I'm going to have to paint a picture with words. I have a chart up here, and it says that younger adults, 40% have suffered from anxiety and depression as a result of the pandemic. When you look at, so that's 40 is our baseline for younger adults. Ages 65 to 74, that number is 26%, significant difference. And if you're 80 or older, 19%. So here, being older confers some advantages. So as we talk about things that put us at higher risk, we also need to look at those things that offer us some protection. Let's look at the next chart that I'll have to paint a picture with words. This one is a little more nuanced. We're looking at anxiety and depression in older adults in different population subgroups, because not all of us that are older are the same. There's a lot of diversity, and diversity of all sorts. So if we look overall at people that are age 65 or older, again, the rate of anxiety and depression is about 24% during the pandemic. That rate goes up to 27% if you live alone. Females have a slightly higher risk, 28%. Hispanic people, 33%. Folks with limited income under 25,000, 37%. And then being in fair or poor health confers a 48% risk, double from the overall average. Now, these are looking at each of these factors in isolation. Many people have more than one of these factors. So that lets us know that we can give an overall number, but there's a lot of diversity that makes up that overall number. Okay, now we're looking at the pandemic's effect on mental health and social isolation. And what are the increasing levels of feelings that older adults are reporting? Well, the most common, 57% of those reporting, is frustration. Now, if you've not felt frustrated during the pandemic, I hope you'll tell me about that later, because I have felt more frustrated more times during the last year than I can remember in most of the prior years combined. Increased stress, about 45%, anxiety, 41%, sadness, feeling overwhelmed, and loneliness. So part of this is just to show that there's a lot of different feelings, and the feeling of loneliness doesn't predominate in this survey. It's been more these frustration, stress, anxiety about the situation. Those of you on the phone, I hope that trying to describe the charts we're looking at in words is helping you. I can imagine it's a little bit of a challenge. But the purpose of the chart that those of us that are looking at screens are seeing is that it looks at rates of anxiety, depressive disorders, and stress-related disorders between older and younger adults. The message here is, the younger you are, the more anxiety, the more depressive disorders, and the more trauma or stress-related disorders. And those go down as you age. So there is an inverse relationship. Just to give you order of magnitude, if we're looking at people 18 to 24 years old, 52.3% are reporting during the pandemic depressive disorders. Compare that, 52.3% to 5.8% in folks 65 or older. So we've gone back and forth with some pretty negative news about the increased risk of death to some very encouraging news about some protective effects as you age from the mental health effects during the pandemic. I think that's the last of the charts, so maybe it will be easier for those of you on the phone to follow. So I want to continue on this positive tack that we're on. And older adults have shown higher resilience to COVID-19 mental effects. So they are subjective to the same situation, but they tend to not have the same reaction. And we know this is because of some internal factors. Again, the biological stress response is dampened down a little bit as we get older. Cognitive capacity, we actually do gain wisdom as we get older. Personality traits become more patient, been there, done that, seen that. And then physical health matters if you have good physical health. And then there's social factors that make the mental health effects a little bit easier on older adults. And that has to do with social status and financial stability. That tends to get a little better as we get older. Also, this was a paradox I found in my reading. The COVID-19 protective measures, the things we hear the newscasters and people rallying about on the news, like avoiding, not doing any unnecessary travel, use of public transportation, staying away from public places, wearing your mask, etc. Actually, for adults who have been, older adults who have been more compliant, have lowered COVID-19 anxiety. So the things that many people are getting so distressed about have actually been a comfort to some older adults. Okay, the next slide is my very favorite slide, and I hope someday to develop this idea further and do a whole talk on it. But this is the title of this slide. There is a significant inverse relationship between loneliness and wisdom. So if one is high, the other's low. So if your wisdom is high, your loneliness is low. But what is wisdom? I think if we asked everyone as part of this presentation to define wisdom, we'd have probably quite a plethora of differing opinions. But what I'm going to use for today is that it's a very complex personality trait, and that's what makes it a bit hard to define. But the wisdom that we see in older people includes these characteristics, is a tendency more towards empathy, to be able to understand the circumstances and sometimes the suffering of other people without suffering yourself or being in that situation, and the compassion for other people, the fact that we care what's happening to other people. That's a very big part of wisdom. As a matter of fact, in studies, compassion has been shown to be the biggest contributor to wisdom. So then we have emotional regulation, which I've talked about several times during this presentation, that adults kind of run more steady than up and down that we see in younger people. The ability to self-reflect. Well, you know, I might have thought about this being a really big deal years ago, but now that I've experienced it a few times, it really isn't. You know, I always say to my family, nothing fatal, right? We're okay, let's go. Decisiveness, that's part of aging also, is the ability to make decisions easier and with more confidence. Social, we tend to have, we have the folks that are disparate that don't have social connections, but many older people have very long and enduring social and family connections. And then wisdom is also a very important characteristic, is spirituality. The belief, whatever it is, I'm not talking religion, I'm talking spirituality, the belief in something bigger than us. And the trust in that tends to help with wisdom, which again helps to dampen down loneliness and sometimes other mental health problems. So I loved when I started reading about the studies on wisdom, and there's a fair bit of work out there on that. Okay, so earlier they told you that I host a radio show and we talk about problems and we talk about what the policy solutions are. And I have a hard and fast rule with my co-host or anyone who is a guest on the show. We can say how bad things are. We can say how we think we need to fix it. But most importantly, I must tell my listeners what they can do. So this slide is holding true to that, which I do with my radio show. What can you do to work on to protect yourself from some of the mental health problems and to prevent loneliness? Is you must prioritize socialization. Now, I think we've learned during the pandemic that socialization can be done lots of ways. You can engage. Before I move off socialization, we have learned it's not the quantity, it's the quality. So I always tell people you may not be seeing your family as much, or you may be seeing them on FaceTime or whatever other video service you use. But when you're with them, get connected. Make sure you make that real connection and that you have quality and you're very fully present. Physical activity is wonderful in helping to improve our moods. So I see I wrote physical activity twice, sorry. And preferably go outdoors. There's something about nature that helps us to get outside of ourselves. Stay mentally active, whatever that means to you. Reading, doing crafts, doing word puzzles, playing games, doing digital online puzzles, doing the puzzles in the box. I'm terrible at it. I don't know as much as I'd like to know about compassion training, but I'm very interested in this idea, is that we can actually go and, like other skills, learn to be more compassionate. And that has it is the major contributor to wisdom, which helps us live our lives maybe more fulfilling and a little less hard. And then spiritual activities whatever those are for you. Now, the main thing I do in my role at the University of Tennessee relates to policy, public policy. And there are several things, and particularly if you're engaged locally or at the federal level with policymakers, or you cherish your right to vote, you want to be an informed voter, there are things we need to look at. We need affordable and accessible mental health care. The pandemic has really highlighted what a weak infrastructure that we have around mental health care. But just as it's highlighted the weak infrastructure, we have seen the biggest boon in the change in the delivery of care, and it's been most effective in the arena of providing mental health and treatment services for substance abuse through telehealth. So we have some things to build upon. We need to quit looking as a country at mental health and physical health as being separate. When you go to see a provider, there should be no separation between those two. That just as we're assessing your blood sugars and your blood pressure and how well your kidneys are working, we need to know about your mood and your cognitive functioning, etc. We need, not only do people report higher satisfaction with being at home in times of disability or when the care needs are high or time close to death, we know that it actually is very beneficial from measurable impact. So we need to start looking at how we can reconceptualize what we do with people as they age or as they're in the end of their life. And then we need, in our country, better funding of social programs. Now, I'm going to draw a picture, and I don't even have a picture for the people with the screen. When we look at what comprises health, I might ask this question of new nursing students. Well, the answer very glibly, as only a 20-year-old would say, well, of course, health is the same as healthcare. No, it is not. We have measured through studies, not me, I use the term we just as a form of speech, have measured what contributes to health. Clinical care, the care you receive with physicians and other healthcare providers at hospitals, at clinics, etc., only contributes 20% to your health, which is measured as the length of your life and the quality of your life. 40% of what contributes to health has to do with social factors, your education, where you live, work, and play. Pardon me, the environment where you live. That also has a separate contribution. The other big thing is our behaviors, what we do, self-care, our habits. But I always say that the choices you make about whether you exercise, what you eat, etc., are in large part based on the choices you have. So we don't all have the same opportunities and choices. So that's why funding social programs is so important, and to begin to look at that sending someone home on an antibiotic for a badly infected foot that lives in a less than clean environment, doesn't have money to buy their antibiotic, doesn't have access to some of the supplies they might need, it's not going to work. Okay, then I want to end with relationships matter. I think if you were to take one thing away, have you ever gone to church and you walk out to shake the preacher's hand or whoever is your spiritual or religious leader, and you say, that was a great sermon. I've done that before. And then you're walking to your car and your husband says, well, what was that sermon about? And you can't even remember. Well, you're kind of like, it's the relationship. It's the way that you felt during that. And then later on, hopefully you'll recall, it might not have been the best story here, but human contact is essential. We are social animals. And one of the things that we have to guard against as we age is that our social networks do tend to thin. They're not quite as rich and thick as they were. Think about how social you are. I see my son who's in his low 30s, and you know, being with your friends and being out and about a lot really matters. And I think that's part of the reason that young adults have suffered so much during the pandemic. So because our social networks are thinning, we need to be more proactive. We've got to say, well, I can sit here and lament that so-and-so hasn't called me or I haven't seen so-and-so, but then I could say, well, what am I going to do about it? And reach out to folks or write notes, do letters, things like that. Okay, I see I missed one of my slides, but that's okay. I'm going to end with, I'm looking forward to your questions and comments, a shameless plug for my radio show. I love to hear from listeners. I love ideas for shows. And then my email address is here. So I am going to end this slideshow. And I don't need to share anymore, Angela. I'm trying to think how I get out of here.
I think it's at the bottom of your
Okay,
screen.
I'm trying to find it. It usually is. Oh, I bet it's on the bottom over here. Sorry, I'm trying to get out of this, Angela. Now you can see my email. That's not good. It's ugly. Okay, here I go. I found it. Let's see. You are sharing your screen. I want to stop sharing. Stop sharing. Here we go. Sorry, this is a different system than what I use. So
I am going to unmute everyone, and if you have or ask you to unmute yourself. If you have any questions, please feel free to ask, and we can start our question and answer session. So you can unmute yourself now.
I saw that the men have the highest incidences of suicide, but the women are depressed more. That's interesting.
yes, it is. And that's not just something among older Americans. We see that across the board. And that we see that across the board. And we also know that the suicide profile of men is very different than females in that men tend to have more commonly a first lethal attempt or to use more lethal methods than women do. So there's a lot of gender differences there. But I'm intrigued that you picked up on that, but that's something that's talked about a lot.
Also, as a person of color, when my mother died, I had situational depression. I lost like 60 pounds, and people were worried about me and all that good stuff. And I worked at the hospital then, and that was before I retired. And actually, my doctor insisted that I come to his office, and he ended up putting me on something, and I started to feel better. And when I shared that, somebody really blasted me for saying, "I thought you were a woman of faith. Why would you take something?" And so I noticed when you were saying we people of color don't always seek out help. And I was wondering if that could be part of the cause, is because we're not supported in that effort among our peer group or our church group or whatever. So yeah, it made me feel really crappy, that I thought I was doing a good thing. And then I found out that I wasn't. So
no, you did a good thing. Because
well,
again, you said the magic word, at least to me, is that you did feel better. Depression is generally treatable, but our people, whoever our people is, each of us have different groups that we're in, greatly influence our behaviors. And we know that there's stronger stigma among people of color about mental health care. And then you named another group, people of faith. I actually, I don't in any way purport to equate this with your experience. I had someone in my church challenge me if my faith was strong because we were doing online church services. Well, here's my reply. I fear the virus. It's killed over 500,000 people. I fear the hot oven and I use a mitt, just like I use a mask when I go outside and I don't go where I have to go. So I think somehow in our country, too many things got politicized, and has made it very, very difficult. And sadly, some of those very same polarizing views and statements were seeped into our churches and other social organizations. It's really pervasive in the fabric of our life right now. So I think it takes strong people to say, this is what I believe in. I don't think wearing a mask in any way has to do with how strong my faith is. And I think if I'll tell a story that's very similar to yours, but it's not the same. A young student of color, a young woman who's very young in college, she moved through high school very quickly, came from a homeschooling environment, African American young lady, fundamentalist religion. And one day I said, something's seriously wrong. I suggest you go see a counselor. I thought she, as a nurse, she had all the signs of very profound depression. Well, she did. And she'd start taking medicine, started feeling better, went home over the break. And her parents shamed her so much that that's not what we do. Our people don't do that. And she was a wreck. She came back to school and said, I was doing better. I'm afraid. But, you know, that's her family. That's her church. So, yeah, that we are bound up by a lot of social and cultural constraints and also enablers, barriers and enablers. But I applaud you for sharing your story. I don't know your name. It says vet.
Oh, you're muted, Yvette.
Oh, Yvette. Okay.
Yeah. Let's see, unmute.
But thank you for sharing that and a great observation.
Hi, this is Courtney Neiman. I work at the Metro Drug Coalition, and I have a question.
Oh.
In any of your research that you have done over the years, do you see a more acceptance with certain age groups of taking medication for anxiety or depression? Does it lean more towards adult or older adults? Just curious.
No, you know, Courtney, I don't actually think I have seen that. I'm trying to think. We know, I can't talk about, you know, prescription drugs for appropriate purpose, but in substance misuse, Courtney, that it could be prescription drugs or non-prescription drugs, that misuse is lower among older adults, but it's growing. See, there's a contradiction there. There's a low baseline, but we've been seeing more prescription drug misuse.
Well, I guess this would be more of like the acceptance of actually taking medication for depression or anxiety. Do you see within certain age groups that are
I
more
didn't see
acceptance?
anything about that. I saw it across different population groups, not age groups. I'll try to look that up. You're at the MD where Karen Pershing is?
Yes, that's my supervisor.
Okay. All right, I'll try to remember. And Courtney, I'll write your name down.
What populations did you see it in? More accepting?
Well, I think what we heard was who's not accepting is populations of color sometimes.
Thank you.
Thank you. Again, the questions are my favorite part.
I have a question that was texted to me. What mental health challenges should we be considering in older adults on the other side of the pandemic? More specifically, do you think there'll be challenges that are going to come with resocialization once it is safe?
Let me collect my thoughts because I can think of three kind of veins here I'd like to talk about. There's a lot in the literature right now. You know, we are starting, we think, we hope that we're starting to emerge from the most acute phase of the pandemic and that we're dampening the curve, although we're still at a terrible place. But as we continue, as more people get vaccinated, there's some people that saying as that curve goes down to the acute phase, we're going to see a rising, lagging amount of mental health disorders. And it's going to be chronic things that, and that was one of the slides I had about stress-related disorders, even like post-traumatic stress disorder. We also know we already have a cadre of people that have been sick with COVID-19 that are now being called long haulers because the COVID-19 acute illness persists and persists, and we think now it's going to become a chronic disorder, the damage that was done to the lungs. So if you think about that relationship between chronic disease and disability and mental health problems, I think that's going to be part of the reason for the lagging rise in mental health. But then on a separate note, and this is just conjecture opinion, so anyone can challenge me or share a different perspective, that what is going back to normal? I don't think that, I think we'll have a new set point. I think our expectations, and I had a friend the other day say to me, I know who I missed during this past year, but I know those things that I don't miss and I'm not going back to them. So I think it helped us maybe kind of separate the wheat from the chaff. Is that the expression? The wheat from the chaff? Is that maybe some of those activities that we think we have to be frantic to always be involved in and collecting all these social contexts, maybe some people have said, I'm going to go with that adage, quality, not quantity. My husband and I used to think that, oh, what a drudge. We have to go home and eat at home. We want to eat out all the time now. I'm like, I don't think I'll ever eat out like I used to. So I think there's going to be a lot of changes. If you think about major pandemics in the past, think about the Dark Ages, the bubonic plague, what followed with almost a third of the world population dying, the Renaissance. And then what happened after 1918 flu epidemic? We had the Roaring 20s. So I think it's hard to predict. I have made it a habit to pull all the things I can, people making predictions about the post-pandemic world, but it's yet to be seen. But I think people will reassess what's important, particularly older people, because we're wiser. Remember, wisdom.
Right.
Yeah. Does someone have a different perspective?
I don't know if it's perspective, but I have never married, and since I left my mom, have always lived alone. So it's, I enjoyed going to the senior center and, quilting with my little group, and I was in the senior band there. And so I would like to get back to those. And right now I know one of those things when you were doing your hierarchy of things, one of them was a fear. And I have just been afraid. I mean, my sister wanted to come over at Thanksgiving and I would not let her because she works in healthcare and 4 of her coworkers had COVID and she's not taking the shot yet because she's afraid and I haven't had it yet. And so I've been hanging my clothes on a clothes rack since probably shortly after March because my dryer is messed up. And so I'm not ready to have somebody come in and take a look at it yet. So, I don't know how long after I get the shot and then how long do I wait until I start feeling comfortable enough because yes, I know it's real and I have a fear and I am a woman of faith, but I have common because I'm 67, and so I feel like I've got wisdom now because I'm older. So I want to be prudent. I want to be prudent and smart, and making my. But I don't want to become where I'm a recluse either, where I just decide, okay, I'll do better just to stay in here and never go out again.
Yeah, well, I debated about whether to include anything about the vaccines because I think that's really in part things that need to be considered with what you said. I think if we follow the science, So I'm declaring myself as someone who follows science and still a person of faith, that getting your vaccines and still protecting yourself and being careful who you're around, being judicious about not going around people who haven't been vaccinated, I think will help to ease those fears. I think we're all going to have a little bit of trepidation, I went to church one time during the pandemic and people got too close and didn't go back. I watch it on TV. But I really want to go back. And where actually people are riding on a board, I've gotten both my vaccinations to show that it's becoming safer and safer. So I think it's natural to have some trepidation given what we've been through. But I prefer to look forward, but be wise about it and be careful who I'm with. And then also be selective. I'm not going. There's two big family get-togethers when there's a lot of young people who have been very cavalier about all this. So, I think it's just being judicious and weighing, we got to get out some. We got to get out. Sophia, you're on mute.
I muted you, Mary Sophia. There's some feedback.
Okay.
Oh, Mary Sophia. I could remember Sophia.
Here we go. Now I lost my track of thought. I've been working from home since March 16th of last year. And part of that was not difficult for me because I have rheumatoid arthritis and fibromyalgia and several other things that impact my health as well. But we're expected back in the office on Monday. And I've talked with my rheumatologist and doing all the things we're supposed to do. But I will admit, and I am a woman of faith as well, but I will admit I disagree with that decision, but I don't have much choice in it. But I have wondered now for at least a month, what's it going to be like when we go back out there? And I'm concerned because I know that the people who've persisted in not wearing masks are going to persist in getting in my face and are not going to follow good practices. I can follow good practices and I can limit where I go. The idea of eating in a restaurant right now, just, I drive by restaurants and see their food and I just wonder what people are thinking. And so for me, it's a certain amount of cautious alertness, and also just, some hermitness, because I've been doing the online grocery shopping, driving up and picking it up, and all those things. I just don't go anywhere except the doctor's office. So having to be back there trying to face all this, it's intimidating.
Yeah, no, I think there's going to be an adjustment for all of us. Angela, you're on mute. You can tell I teach online. I have to scan my students all the time.
I was telling Mary Sophia she was on mute too, in case she said anything else. Yeah, she knew. Yeah, I definitely think that there will be a getting used to it, though I have to say that our office remains most of us remained coming into the office. Some were able to furlough a little bit, some were able to work from home. But as I've seen other friends and worked from home maybe once or twice, I realized that seeing my coworkers actually was a lifeline for me. And being able to see people daily and not being stuck at home with my dogs and cats and only my husband. Bless him, he's a sweet one, but I got to see a little more than that. And so I never really got the full, I guess, social isolation part of it, the whole isolation bit. But we have stayed home a lot, and I've noticed seeing people on TV without mask in large groups, even if I know it's filmed a long time ago. Seeing that, I'm like, ooh, that doesn't look good. And I get nervous for them. But I do think that I'll probably still continue to wear a mask if I ever go on airplanes again. Always, mostly because I would get the crud afterwards, and be a little sick after being on an airplane. So I think that, yeah, that's one thing I definitely will continue.
Well, you know, in Japan, mask wearing long before the pandemic was pretty normalized. Yeah.
And that totally makes sense to me now.
Yeah, really, really.
But if anyone doesn't have any more questions, we value all your time, and we appreciate you so much, Dr. Myers, for being here and discussing this, because it is yes, Peggy was clapping. It is a pressing matter. I know a lot of us have felt this effects, and now, you know, we also help folks who are feeling this every single day.
Great. Well, my pleasure. I always enjoy meeting with the group. My association with, well, not the office, I'm thinking about the Connor Center. I moved to Tennessee in 1977 and went to graduate school at UT as a family nurse practitioner and provided physical exams there at the O'Connor Center as a student. And then I kept coming back afterwards. So I appreciate the association with folks like you that are working together for healthy aging in our community and providing support. So thank you very much. And I will, I'll get you a copy of the slides. Was there, oh, you asked me for a couple of fact sheets too that I saw. I'll send those to you.
Yeah, whatever you could send, we can send out and distribute for folks that are interested.
Okay, thanks.
Thank you. Thanks, everyone.